So I'm just going to quickly run through. We have some kind of business as part of our CME accreditation to take care of. So I'll talk through those disclosures. So we had a group of clinicians, many are who and ethicists who are here today. And I'd be remiss at not mentioning our partnership with the Champlain Center for Healthcare Ethics in organizing this session today and participating in the determination of the speakers and the content for today. We have just the presenter disclosures here. So Dr. Levitt and Dr. Buckman, I'll just let folks read that. And then Ali Ladak from the Champlain Center for Healthcare Ethics, as well as Dr. Delakia. And there's no additional financial support for this session. As part of our accreditation for this event, we have reviewed this material. Our scientific planning committee have reviewed this material, and the presenters were provided with information about management of conflicts of interest. So without further ado, these are kind of the overall objectives of our session. We want participants to be able to describe the concept of suffering as it relates to individuals with serious persistent mental illness, to identify the elements of a palliative approach to care for people with serious persistent mental illness, talk about ethical dimensions of care, and then learn how to better apply a palliative approach to care for people with serious persistent mental illness through some case study examples. So I'm going to stop sharing my screen and turn things over to our colleague, Sarah Anderson. Sarah Anderson is a nurse and a colleague. She is the Director of Care at Royal Ottawa Place here in Ottawa. And Sarah and I have had many a conversation about how to improve palliative care for this population. So really grateful, Sarah, that you've agreed to be our moderator for today.
Thank you, Val. Thank you so much. I'm so excited to see so many participants at such an important talk today. I'm Sarah. I'm the Director of Care and Interim Administrator at Royal Ottawa Place, and it's a long-term care home here in Ottawa. And the majority of our residents live with a severe and persistent mental illness. So I get to see firsthand the challenges of providing palliative and end-of-life care that meaningfully accounts for the impact of mental illness on communication, decision-making, and symptom experience. So this is certainly an area that needs greater focus so that we can improve the quality of life at the end of life and ensure that the care we provide is ethical and equitable and person-centered. So thank you. Before we begin, I'd like to note that we won't formally be introducing each of the speakers today. Their biographies are available in the event description. So I encourage you to take a moment to review them as our speakers bring a wide range of expertise and experience in this important conversation.
I'll share my slide deck and I hope everyone can see it and hear me as well. I wish to second the welcome extended by Val and Sarah. I think it is intensely meaningful for everybody to join at this hour. I'll take the first step to take everyone through the larger concept of suffering and what it means as it applies to people with severe and persistent mental illness. Yes, and as mentioned, I have no particular financial conflicts to disclose. I am immensely grateful for many people, and some of them are on this call. Of course, thanks Dan for the mentorship, which goes back to many years. Thanks Ali and team and the ethics team at the Ottawa Hospital and the Champlain Center for Bioethics here in Ottawa. And of course, many discussions, many intense, long discussions with my patients at the psychosocial oncology program, which has allowed me to gain unique insights in this in this area of suffering and what it means. So thank you. As was mentioned in the learning objectives, I plan to take you through a reflective journey. So it's a discussion platform that I plan to lay down with regards to what it means to suffer if someone is going through severe and persistent mental illnesses. We'll look at the conceptual background as well as look at it from a clinical lens. We'll obviously adopt many different lenses as we go through. But the larger idea is to see if we can apply a narrative and a relational approach to understanding what suffering means. And I'm going to juxtapose this with what care as a whole, as an umbrella term, means when we are working with patients with severe and persistent mental illness. I'm particularly interested in engaging with you all in this reflective journey and discussion. And what better way than to start this discussion from where it all starts? And it's the lived experience, which is where the idea of suffering gets its origin from. So if you look at literature, there are published lived experience from people with severe and persistent mental illness. And for those of us who work in mental health, this is not a new scenario at all. What you are reading through on this slide is something that we in our clinical world see day in and day out for someone who has got a chronic mental illness, which spans years of their most functional life, limits them from functioning. Often symptoms continue to persist despite best efforts from everyone. And what it starts affecting is goes beyond just the symptoms and the distress associated with it. We look at aspects where patients go through difficulties in housing, difficulties in choosing, and having side effects to medications, which again may not be able to completely remit the symptoms. We also encounter various different challenges with regards to these patients having social relationship problems, narrowing of their repertoire, employment becomes a challenge, and so on and so forth. So uh, the narrative around a lived experience for someone going through severe and persistent mental illness is really profound. And I often find myself asking a question as a clinician, which is obviously a dichotomous answer that comes very easily. So, what is the patient treated for? And it's obviously the chronic and severe persistent mental illness. But I reflect back on it and trying to ask myself that am I asking the right question? Because I believe a better question to ask is what is the patient actually suffering from? And the moment that question is asked, the floodgates kind of open because the narrative around suffering is not limited to any aspects or every aspect of the illness itself. It goes way beyond, as is shown in this published lived experiences of patients who continue to suffer from severe and persistent mental illnesses, be it the challenges with stability in the aspect with the illness, be it with the aspect of uncertainty, be it a theme of how they are challenged day in and day out with the symptoms, which many a times remain invalidated. Um, More importantly, many times severe and persistent mental illness can compromise the very identity of the individual, and who they were as people, as persons, shifts to what the illness starts defining them, and that can be really undermining to their own self-worth. Um, and add on to it a social layer of how the society views them, or gives them the position that they had before, the role that they had before, and the role they do not have anymore. And so these are layers and layers of themes that come up when we change the question to what the person is suffering from. And as I continue to reflect on these dimensions, a few clinical thought processes come to mind with uh, regards to this space in severe and persistent mental illness and suffering, where obviously, despite treatment, many people have preserved insight, some people do not. And despite the best stability that is possible with the symptoms, you will continue to see that the suffering may continue to persist. Uh, what patients with SPMI fear the most is not always the symptoms themselves, but all that is associated way beyond and above the symptoms. So all these social determinants of health come in and start getting factored into identifying their suffering. So be it the loss of self, the fragility that comes in, the erosion of dignity, and so on and so forth. The illness was only a part of their problem. And again, it's this unique subjective experience that one is going through, the idea of social isolation, stigma, the existential instability of who they are as people starts defining their suffering. Um, and finally, the individuals with severe and persistent mental illnesses may certainly not be imminently dying, so they're really far away from death or dying to happen. But again, they might not be very close to what it means to live meaningfully, and so that's kind of the challenge that people with severe and persistent mental illness often face, with each person describing suffering in their unique, personal, internal way, which at times crosses the bar of intolerability. So I think in preparation to this talk, I did reflectively ask myself this question, and I put this question in front of this audience, that in the context of SPMI and people with suffering with severe and persistent mental illnesses, how do we understand suffering when it is such a personal experience, when it is so fragmenting, and when it is so existential? And as many of us who have often gone down this path, it is often an internal journey to understand what suffering means. Sometimes it is external, and sometimes it ends up in a rabbit hole. I went through all three pathways. So the idea of, and I'll present to you a few of the conceptual understandings based on literature on what suffering means as a whole, and then we'll go on to what suffering means in people with severe and persistent mental illness. So first of all, what suffering means as a whole. And thankfully, there are three core recurrent threads which kind of explain what suffering means. The first of it is often described as a threat to the human agency. So as human beings, as a species, we have a sense of agency, and anything that provides a threat to it is often seen as suffering. This could be disruption, destruction. There could be many such words which might end up describing this threat, but that's one component of the definition of suffering. A commonly linked component that follows this threat is what the threat does to the person, and that's it causes or contributes to a profound loss. And the loss could be in meaning, in purpose, in physical, in psychological, in social aspects, but it is profound, and it can be a mood alienating experience. And finally, the last part of the thread is the experience as a result of this threat, the secondary loss that happens due to this threat, and the resultant experience, which is often termed as negative. And the extremes of negative, the words do describe that as torture, And sometimes it is also described as a negative transformative experience. And we'll talk about that more in the subsequent slides. So these are the three pillars of the definition of suffering. But this does leave us with a lot of ambiguity and nebulousness with the idea of suffering. And so if you're looking at it from a purely medical and a phenomenological lens, and this is the lens that is often used by healthcare professionals across the world, it is also the lens that is used in the MAID legislation for defining intolerable suffering. And this is a famous definition that was given by Eric Kessel back in the early 1980s when he described in his seminal paper, The Nature of Suffering and the Goals of Medicine, in the New England Journal of Medicine, where he went on to describe it as a state of severe distress associated with events that threaten the intactness of the person. And this definition has got three large components, and I'm going to kind of separate these three one after the other. The first is the state of severe distress. So what you will be seeing or what the person will be experiencing is a negative experience. It is severe and that the distress is expressed. Now, there are various ways in which the distress can be expressed or not expressed, but that's one component of the definition. Then comes the other component of the definition with which we talked about earlier, which was the idea of threat to the agency. And the threat to the agency here in this definition is about the intactness of the person. And what are we talking about in terms of intactness? Eric Kessel referred to this as physical, psychological, and existential. So anything that threatens the physical, psychological, or existential intactness of the person and contributes to a state of severe distress and that is associated with this threat is defined as suffering. And this is the medical and the phenomenological lens that a lot of healthcare professionals use. Is this sufficient? Is this enough to describe the entirety of suffering? Certainly not. And any discussion on suffering would be better if we do not discuss the philosophical lens of suffering, because philosophy does give us the depth in understanding. And this is certainly not a space large enough to discuss the philosophy of suffering, but I'll take you through some of the important themes that are out there in literature to understand this concept. Firstly, Husserl's aspect of suffering, which kind of looks at it from a sense-making experience. So it is the sufferer and the sense that the sufferer makes of what is happening to him, her, or them, and how do they make sense of it. So it's the lived experience that we talked about. Um, Heidegger kind of deviated a little bit from the concept and said that it's really difficult to separate the suffering from the sufferer, and it's an integral part of the entire experience. So you really cannot differentiate that very well. So Heidegger said that it's more to do with the very essence of being in the world. And most recently, it's Gadamer's hermeneutic approach that many of us might be familiar with, because it does give us a very comprehensive idea about what a sufferer is going through and why. It talks about cultural, historical, temporal, personal, and social context to the sufferer, with everything and anything that the person has experienced, whether it is before the event, like for having, or their own perspective about what they are going through, or that is often called as foresight, and one's anticipation of what might happen. So that's the foreconception of it. And that gives the entire kind of universal experience of what it means to suffer. And so that's the philosophical lens to suffering. That may not be just enough to make the understanding of suffering complete, because there is another theory of suffering which is called the praxis theory of suffering, which talks about how it is expressed. And many of us know that that suffering can be expressed in various different behavioral states. Sometimes it is suppressed, sometimes it is tolerated, sometimes it is expressed without restraint, and that bar is a moving bar. And this is the praxis theory of suffering. Um, there's also the social approach to suffering, which typically answers the question, why me? Why am I suffering through this, whereas someone else who is better off is not going through similar experiences? And that's kind of gravitates to the idea of justice or fairness in the society. And this dialect or the dialogue is all about how living in the society, and that's not a fair deal, and that some people get the worst end of it. And that brings out the entire social approach to the understanding of suffering. Um, I am no expert in the idea of religion or the secular domains or the perspective that come with suffering, but I thought it is worth including that for the audience on this platform, many of who might be tuned to this idea of suffering and this perspective that has been there for ages now, and that has provided often a larger than life perspective on suffering, where often when religion is used as a lens, the overall story ends up having a larger purpose and goes beyond good or bad. So that's this entire literature around religion and how it sees human suffering as. So as a whole, as I come back out of my rabbit hole, the idea about what suffering means is to be to summarize in a nutshell, it doesn't sound that it's a brain problem at all. What it looks like, it's more of a human, a species problem. Um, I'm going to deviate slightly away from this ubiquitous dialogue about subjective and objective, because from the literature that we just reviewed, it's so much about the personal experience, and subjective objective domains and those dichotomies do not really cover the entire aspect of suffering. So I'll keep it as personal, but still it is not inaccessible. So yes, one can access it, one can look into it, one can feel it, um, and one can measure it as well to a certain degree. When we look at ethics of suffering, you start thinking about how it is a value, and it is a negative value. It's a negative experience altogether. With the idea that once someone is going through that, there is an intuitive moral obligation to do the opposite, that is to care. And that's where the juxtaposition between what suffering means and what care means come together. And this is kind of the idea of suffering currently in my head, and it could be something that can modify over a period in time. But yes, it is about these three different worlds. One is the internal world that is mediated through social, psychological, existential, physical aspects that provide that meaning to the sufferer. And then there is this very experience of suffering, the personal experience that can be expressed or not expressed in various ways. Then it is juxtaposed with what it means to be cared for in a society across care pathways. And that's how the suffering has seems to be laid out. So it's not necessarily only in the internal domain or the external domain. It lies somewhere in between across this platform. And so, having now had some bit of a background of this concept of suffering, how does it apply to patients with severe and persistent mental illness? And I was pleasantly surprised to see a lot of literature around what suffering and what it means in people with severe and persistent mental illnesses. This slide aims to take you through the narratives of it, largely dominated by daily life challenges, the severity and complexity of these lived experiences, the circularity of life with SPMI and the coexisting conditions. all leading to loss of control as the central theme. But that's not the only theme. There's the cycle of burden, and that SPMI does not really give up. It keeps coming back every day. There's this central theme of loss of identity and meaninglessness, caused by deep emotional distress. There's, of course, this idea of social isolation and loss of social connectedness. Um, Often the boundaries between what is a good life and what is a good death gets blurred in SPMI, and that gets expressed in the narrative on suffering. The German aspect of how much suffering there is to live through often gets expressed in this field in people who suffer from a severe and persistent mental illness. And so it's the agency of who is the sufferer often gets expressed. Um, Treatment fatigue, the idea of futility, and I'm sure Dan and Sarah would kind of focus on that when they do that discussion. But that has been a central idea of suffering and what it means. It goes just beyond the success and failure dichotomy, whether the treatment has succeeded or failed. The fragmentation of care systems, the lack of integration, the barriers that people experience gets expressed. Of course, the psychological pain, the spiritual annihilation are all central themes to suffering. But what I also found is a little bit of a golden lining, if I may say so, with the work on suffering and how there can be the idea of this sense making process where reframing of the very experience of suffering can happen through healthcare pathways. And so, if I were to summarize my themes from this, um, there are these central three themes that I could come across. One is, of course, the nature of living with SPMI, and so it's really precarious. It's a roller coaster ride, a constant sense of unpredictability. People who take just one day at a time, they're not able to see beyond that, and that really contributes to suffering with an overwhelming nature of their short-term needs kind of encompassing their own identity. And then finally, the blurring of the good and the bad choices. The physical health gets a beating, often sacrificed because they're to pursue these short-term needs. Um, the other theme is this constant search for meaning. And for those of us who work in Ottawa, we are blessed with such institutions like Psychiatric Survivors of Ottawa, who allow such platforms to happen. I'm sure wherever you work, there would be such platforms. If not, please do look for them, which allows people to have this meaning making experience in their suffering journey. And finally, the theme around supporting the whole person. And how many of us know that people who come for their long-acting injection for long-standing mental illnesses are value that important discussion with their nurse, who takes that 30 minutes or a half an hour more to dive into what they are going through and understand, that goes beyond discussing the side effects of that medication. And so that really is about all the support networks that go beyond treating SPMI. Um, so that's kind of the central theme, and I think I leave you with this thought process in mind as you kind of reflect on it. But I'll also take you through something into the future, which is kind of part of the reason why a lot of people, of you might be on this call today, is an eye on around this time in February in 2027, where you might have the MAID legislation open up for people with mental disorders, where it is the sole underlying sole underlying medical condition. So made MDSUMC, as it's often called as, and the question no longer, I think, is about what side of the debate you are in, because I guess the idea is not about taking sides here, but it's also about taking the aspect of how do we define care if someone approaches us with a request for MAID. where mental disorders are the sole underlying medical condition. The Parliament of Canada back in 2023 has in February of 2023 has recommended, and one of their recommendations is that 5 months before the date, which is Feb 2027, they need to establish a joint committee, a special joint committee on medical assistance in dying, so that they can review the degree of preparedness attained for safe and adequate application of MAID in this situation. So that's where we are at this point. The key issues that I wanted to highlight in the context of suffering is the setting of the bar, and that's kind of central to the very idea of the MAID legislation, the idea of what is irremediable psychiatric suffering. And so the concept of irremediability and intolerable suffering kind of goes very close hand in hand and can't be really separated. Thankfully, meaning this study does mention that Dutch and Belgium psychiatrists were able to come up with a consensus statement where they could identify 5 diagnostic and 8 treatment-related criteria. To emphasize the diagnostic criteria, one of the key themes that they suggested was to have a narrative account about their suffering, which is important and kind of speaks to our literature that we reviewed. But it also talks about the number of treatments, how much, where should we draw the line? And that's kind of the central question about what is the level of certainty that we as healthcare professionals are comfortable with and feel is morally required, that should draw the line between what is irremediable versus what is remediable. And certainly, we can learn from the Dutch data because they've got years of experience on it. However, there is an element of skepticism on that because the idea of Canadian versus Netherlands MAID legislation is similar, but it's not the same. The key difference that I find is that suffering is often judged by the physician in context of the patient's condition along with the patient, which is different from how the Canadian MAID legislation is laid out, where the subjective component, and it's up to the patient to decide of whether they think that any particular intervention works for them or does not work for them. And so the narratives around MAID request and mental health aspects have been quite vivid and quite descriptive. There are people who are ready to let go, but do not desire MAID. They are in crisis and they trigger urgent requests. They are depressed and require actual help to negate their suffering. There's this element of burden or the lack of worth theme, and that's an unmet need that can come through in discussions. Often the themes are around futility and the associated existential demoralization that comes with it. Anticipatory suffering is again a common theme that comes up with a perceived or future loss of independence or autonomy that people worry about and do not want to be in that situation. Sometimes patients use the MAID language, as it's called, as to communicate their suffering, and it is just that, it's a way of communication. Very often that I found is that there's this central theme of control that they really don't want to go ahead with MAID, but they want it in their back pocket. So they want it as a tool for control, just like people want some degree of control over how they live. MAID is a tool for having some degree of control of how they die, and that's can be a narrative that can come in. So overall, as in the parliament, as it was presented very clearly that irremediability is not a medical or a scientific term, but it is defined by law, and there are these specific parameters that are used to define it at this point in time. And whether as mental health professionals we need additional layers to it is up to us, and it's probably in those 5 months that we need to discuss and deliberate. But overall, what we understand that it's rooted in shared decision making. There's case by case aspects to it. The assessments need to be done in a non-crisis period, in more than one setting, by more than one psychiatrist. And it does boil down to how care gets defined. And that's kind of the next question that I'm asking in terms of how does care get defined for someone with suffering in patients with severe and persistent mental illness. This definition from Baroness Fisher and Toronto is meaningful, but may not be sufficient enough to define care in this space if someone is asking for MAID, for example. And this might be a good question to transition to our next talk, and I'll let Sarah and then take over to help with defining care in people with severe and persistent mental illness. Thank you so much.
Thank you, Swamil. We'll move straight on to David and Sarah's presentation next. If there are any questions, please feel free to add them to the chat and we'll ask them near the end for you.
My name is Sarah Levitt. I'm a psychiatrist who primarily works at the University Health Network in Toronto. A lot of my clinical work involves caring for individuals living with severe and persistent mental illness on an assertive community treatment team and also on an inpatient psychiatry unit. And I have the pleasure of presenting with everyone today. Swamil, I absolutely loved your presentation. So it's an honor to get to go next, but a high bar. Daniel Buckman, who will introduce himself in a couple of minutes, and I work a lot together on this idea of how you palliate mental illness, which is, I think, why we were invited to present here today. So we're going to be talking about how we might move towards a model of palliative psychiatry for folks living with severe and persistent mental illness. Next slide, please. So we don't have any financial conflicts of interest to disclose. There's some other information there reflective of what you saw earlier. We also want to thank CIHR for supporting our work through a project grant. And you'll hear a little bit more about the activities of that grant in this talk. And we also want to thank Lucy Costa, Michaela Forte, Lucy Panko, Kate Ciandulis, and members of the CAMH Everyday Ethics Lab for their support of our work too. Next slide, please. So between Daniel and I, we're going to go over a couple of different objectives. We're going to describe current understandings of palliative psychiatry, discuss some ethical concepts relevant when considering, talk a bit about future directions for advancing the idea of palliating mental illness. Next slide, please. So we'll start by talking about what is palliative psychiatry and how it's been talked about so far. Next slide, please. So we want to be very clear about what we're talking about today. So historically, there has been this concept of palliative care psychiatry, which has been traditionally understood as how you bring really high quality evidence-based mental health care to people living with serious medical illnesses who may be facing issues at end of life or grappling with very serious medical conditions and all that means in their lives. And that's not what we're talking about here. What we're talking about here is really how do you provide a comfort care type model to folks living with severe and persistent mental illness. So this is a really big distinction, and there's a lot more written about it in this paper called Palliative Care Psychiatry, Building Synergy Across the Spectrum on this slide, if you have an interest in sort of understanding the differences a bit more. Next slide, please. And one of the challenges in talking about this is that the idea of palliative psychiatry is really in development. It's a very new sort of concept of care and mental health care, at least as a distinct entity. So it was initially described in the literature in relation to anorexia nervosa about 15 years ago. And really, it was conceptualized in that condition because there's a very sort of clear understanding of how symptoms of anorexia nervosa lead to mortality. It has a very, very high rate of mortality, especially amongst mental illnesses. And then in 2016, there was a proposed definition for palliative psychiatry that came out in BMC Psychiatry by Manuel Traxel and some of his colleagues. He's working out of Switzerland. And that was really the first time that palliative psychiatry was introduced as a distinct model of mental health care. And continuing on from there, there was a lot of theoretical refinement of this concept of care, including looking at sort of, is this even like an acceptable concept amongst clinicians? How might we actually like think about this in practice? And I'll go through some of what that's looked like in the rest of this talk. And it's really in the last 5 years that I would say there's been academic momentum about this. So, for example, AMA Ethics, which has now sort of been shut down, I think, but they did publish a special issue on palliative psychiatry that's open access. I suggest people looking it up. I think it's still available, even though the journal's done. And there's also been a lot of debate about whether or not we should be labeling interventions as palliative and sort of what sort of comes with that label, which we'll talk about today as well. And now what Daniel and I are trying to do along with colleagues and a research team is sort of translate all of these great ideas that people have about care to Samil's point about how we're thinking about suffering and trying to address suffering in like a morally justified way into actual clinical practice. Like, what does that actually look like in the healthcare setting? And that's posing some very real challenges, to be honest. So we'll talk a bit about that today. Next slide, please. And maybe this goes without saying, but I'm going to say it anyways because I like to make sure, I'm upfront about what I'm talking about. When we're thinking about what severe and persistent mental illness is, we're not actually thinking about any sort of one specific condition. What we're thinking about is these instances of mental disorders that have certain kinds of qualities to them. And this comes from a paper by Zoomstein and Reese, where they did a scoping review about what people meant in the literature when they talked about SPMI. There isn't really a singular definition, but there are sort of three specific qualities that seem to come up again and again. One is that these are disorders of a prolonged duration. Two is that they're associated with certain types of diagnoses. So, diagnoses that involved prolonged experiences of psychosis, prolonged experiences of affective disturbance, like i.e., mood disturbance. But it's really not diagnostically coherent. Like, I think increasingly we're recognizing substance use disorders, certain instances of personality disorders, etc., as like potentially SPMI. And that also there's a prolonged experience of disability. So some sort of functional impairment in some area of one's life related to the symptoms of the disorder. Next slide, please. And so when we think about these instances of mental disorders, Traxel, in that 2016 paper where he introduces this palliative care model of psychiatry, speaks about how across different healthcare contexts, folks who live with SPMI are at risk of two sort of sides of the same coin. On the one hand, they're at risk of therapeutic neglect, both because there are certain kinds of system failures that mean that there aren't enough services for them. And also, there just isn't a lot of new treatments that are necessarily in development, especially around certain diagnoses. And on the other hand, they're at risk of overly aggressive care. So we don't have that many options to offer them, and services are lacking. But on the other hand, due to the nature of their symptoms, they may be subjective to the same kinds of medications over and over and over again, despite no appreciable benefit. Or they may be subjected to coercive manners of care, whether that's involuntary hospitalizations or, treatment orders in the community, or, incarceration, because we know a lot of mental health care for these folks is actually provided in like sort of carceral settings. So folks who live with SPMI are sort of caught between these extremes. And Traxel and his colleagues' argument is that we need a different kind of model of care to help kind of get, move past this really difficult position that people may find themselves in. And so they proposed palliative psychiatry, which was really, and you can see on the left side of your screen, sort of their core definition of what that is. And the focus was really on the relief of suffering, to Samail's presentation, and quality of life. And they argued that a palliative care model actually helps with this concept of personal recovery, which is to say, helping people live the kind of life that they want, aligned with their values and their goals for function and the kinds of activities they want to participate in. And in Traxel's opinion, in this article, he said that what we really need to help advance this model and this concept is for a broad consensus on how we think about futility in psychiatry. Because his opinion was that when there are these conditions of futility in the care for someone who's experiencing SPMI, that's sort of the trigger point for when you might think about palliative models of care. Next slide, please. So that's just going over that definition. So since that initial model came out, Daniel and I, along with some other colleagues, have been giving a lot of thought about, okay, but how do we actually think of this as separate from other mental health care models? Because there are mental health care models in the past that have been trying to look at this idea of personal recovery and how we can advance it. So on the right side of your screen, you'll see a schematic that comes from one of our papers that really tries to think through it, where you can see that there are, the symptoms associated with the mental disorder, with the condition, and they can affect sort of someone's psychosocial functioning, and also they can lead to harms for the individual, whether or not that's from the symptoms themselves or from the treatments or interventions required to sort of control or manage those symptoms. The symptoms, the harms, the functional deficits can all lead to these experiences of suffering, which has an impact on quality of life. And then moving down, you can see we go through the different kinds of models to think through how they intervene. So, for example, in a curative psychiatric model, you may be just trying to treat the symptoms of SPMI. So to Samal's point about what kinds of treatments are we giving rather than what kinds of suffering are we addressed. And through that, we hope that there are these downstream effects on, reduction of suffering and quality of life. In more of like a rehabilitative psychiatric model, maybe you're not trying to address the symptoms directly, but really you're taking a very practical approach to, even if these symptoms are present, how do we specifically focus on psychosocial functioning and through that pathway address suffering and quality of life. Palliative psychiatry really looks at the other side of the schematic. So really, how can we intervene or withdraw intervention possibly to try and reduce harms and through that reduce suffering? And then also, are there sort of creative ways that we can think of just trying to understand the suffering itself and address it directly, not through these more upstream pathways? Next slide, please. And so through that, you can think about, applying palliative psychiatry in, a narrow, broad, or very broad sense. So, maybe in a narrow sense, you're thinking about palliative psychiatry as providing more traditional, shall I say, palliative end-of-life care for people who are dying from mental illness. So, really taking those same kinds of interventions that our palliative care colleagues who work with medical illness kind of use. In a broader sense, it's any and all approaches aimed to improve quality of life, even with persisting symptoms. And very, very broadly, you can think about maybe any type of psychiatric care that's not directly disease modifying is a palliative psychiatric intervention. And I think these concepts sort of still need to be clarified. And again, we're still trying to think about how that actually plays out in the real clinical space. Next slide, please. And so, as we're trying to think this through, it is also important to think about its acceptability within mental health care models. So far, this work has only been done amongst clinicians. I'll say that up front. We don't have a great sense of what people with lived experience actually think about this. And that's part of, the next steps of Daniel and my work. But what we know so far is from a couple of different surveys of populations of clinicians. So the biggest survey was done by Traxel and his colleagues in Switzerland, and they surveyed all German-speaking psychiatrist members of the Swiss Society for Psychiatry and Psychotherapy. And they actually got a really, really high response rate that we are quite jealous of. You'll see our results in a minute. And they looked at one, sort of the acceptability of palliative care in general in mental health care amongst this population. And two, they gave them case vignettes related to depression, anorexia nervosa, and schizophrenia, and asked specific questions about palliative types of approaches and how acceptable they were, as well as questions about whether or not this population thought that further curative interventions would be futile. Next slide, please. And so I won't go through all of their results, but some of the key highlights is that, almost all of these German-speaking Swiss psychiatrists thought that severe and persistent mental illness could be considered a terminal illness, which is interesting when you think about it in relation to how we think about when palliative care in general is an acceptable approach in medicine. And also, interestingly, these psychiatrists really reported, in general, they don't see that curing illness is a big part of their goals of treatment, but rather, in general, psychiatric care should be targeting a reduction of suffering, improving daily life function, maintaining autonomy, and sort of in a distant fourth, decreasing suicide. And on the right side of your screen, you can see that broadly over different kinds of diagnostic categories, this group of psychiatrists surveyed thought that palliative approaches would be acceptable in caring for people with those conditions. Next slide, please. So we tried to replicate this study amongst Canadian psychiatrists. We're just finishing up the manuscript and are going to publish this data soon, hopefully. We had a much lower response rate, so we can't draw like massive conclusions from this. We only had 69 psychiatrists respond from like about 5,000 eligible participants. But once again, there was like a high majority, not quite as overwhelmingly high as amongst the German-speaking Swiss psychiatrists that thought SPMI could be a terminal illness. And similarly, like curing illness was really not one of the goals of treatment identified by this group of psychiatrists. But again, like really, they felt that their work should be focused on a reduction of suffering in general. So clearly there's sort of like an appetite, it seems, across healthcare contexts, with the caveat that this is a small sample size, that's what psychiatric care should be focused on. And again, there was broad acceptability for palliative care approaches across diagnostic conditions. Next slide, please. So just to get a bit more granular with the Canadian data, interestingly, there was sort of a split around whether or not palliative care only applies to end-of-life care. And most agreed that palliative care would be indicated in certain instances of people experiencing SPMI, which to me states that, even for people who think it is related to end-of-life care, they're sort of willing to expand that definition of where palliative care is appropriate in SPMI care because they recognize that some of the values associated with palliative care is relevant in the care of people experiencing SPMI. Next slide, please. One thing that we added to our study that wasn't done in the original Traxel study is we actually did a qualitative analysis of free text responses when participants were answering the case studies around how they were thinking through whether or not palliative care was applicable in the different cases of anorexia nervosa, depression, and schizophrenia. And it's the one takeaway point I want you folks to have is that there's really complicated decision making that's going on in clinicians' heads, at least amongst this sample, when they're thinking through things like, is future, intervention to cure controlling symptoms futile or not? Would I be surprised if this person were to die in the next 6 months? What would make me be willing to give up like length of life, for quality of life for this individual. And our qualitative analysis yielded that people were thinking about different kinds of health systems factors, new and emerging treatments. Have people really been able to receive the full scope of treatments? There were lots of different kinds of ethical concerns. Thinking through the characteristics of mental illness and also the psychosocial world of the individual. And finally, thinking through the clinical paradigms that they were using in thinking about these hypothetical patients. And in particular, in the clinical paradigms, MAID came up quite a bit, despite the fact that this is a Canadian population. MAID isn't actually accessible to these patients yet. But it was really, really present on people's minds. So to Samil's last point about, looking ahead to 2027, clearly in these discussions in Canada, that's really sort of dominating the way that people are kind of thinking about it. Again, not trying to draw too broad conclusions from our small sample. Next slide, please. So in terms of where we need to go next to actually bring this into the clinical sphere, there's a lot of different kinds of research that needs to be done. And as I highlighted, we really need the voices of people with lived experience to kind of understand, is this an acceptable model of care, and what might, they want from it, and thinking through what's already done that can be considered palliative, and how we kind of make that a little bit more systematic. And then, I think there's some, anxiety amongst mental health care professionals about, what does this mean for my legal obligations in managing risk? How does this contextually fit into MAID, et cetera? And then a lot of education is going to be needed, both for folks who are living with SPMI, families, and mental health care providers and trainees. Next slide, please. So that's what we're trying to kind of figure out now. And so this is just a general overview of the grant that we're working on. We're actually currently recruiting for qualitative interviews with both mental health care clinicians and people with lived experience. So if you have anyone or you want to participate, please do send us an email. And there's an email at the end of the slide. Next slide, please. And we're really trying to kind of center some of the voices of people with lived experience in this work. We're really trying to think about how do we kind of engage in methods of like co-production, engage people in this work, and really do that in like an ethically rigorous way. Next slide, please. So with that, I'm going to turn it over to Daniel.
Thanks so much, Sarah. Hi, everyone. I'm Daniel Buckman. I'm a senior scientist at the Center for Addiction and Mental Health in Toronto, where I was actually providing clinical ethics consultation up until January this year. I'm also at CAMH. I'm a director of the Everyday Ethics Lab, which is our ethics research lab, and I'm an associate professor at the Dalawana School of Public Health at the University of Toronto. And I just want to say it's just a real joy and a privilege not only to be here, but also to share the panel today with two former master students, Somil and Ali. So get a lot of delight from that. So I'm going to talk about some of the ethical considerations related to palliative psychiatry. Ali is going to, in his presentation a bit later, focus more on some case-specific considerations. And so I'm just going to really give some high-level overview of some of the issues that I see as relevant. Of course, not an entire laundry list of possible considerations, but some that I'd like to focus on for today. I don't think this is surprising to the folks who are affiliated with Champlain and the hospice and palliative care crowd, but the term palliative care has baggage. There's a lot of stigma associated with the concept. For example, if we were calling for a palliative care consult, are you calling the angels of death? If you're calling for palliative care, does that mean that someone is absolutely at the end of life? And I think a lot of folks in palliative care, clinicians and families and patients and researchers and others have been advocating for a very, very long time to try to remove sort of the idea that palliative care is associated with exclusively with end-of-life care. This perhaps has some historical roots in the hospice movement amongst named Cicely Saunders, in the UK. But there's a lot of, I think, societal perceptions about what palliative care actually means. And so I think if you talk to anyone who's actually working in palliative care, you sort of have on the left of this meme, I think it's Wednesday Addams, sort of more of the dark, as thinking of palliative care, where actually many palliative care clinicians have a very sort of life-affirming approach, actually, to improving quality of life and making people working with a comfort-oriented approach to help people live the best quality of life within the condition that they have. And I think, again, not surprising to this crowd, but there's been lots of research as well that has looked about high-quality palliative care and how that delivery of such high-quality palliative care is actually associated with improvements in both quantity and quality of life in people who are living with persistent physical illnesses. So one major sort of ethics concept, Saumil brought this up earlier, Sarah did as well, is this concept of futility. And generally, when we think of futility, or sometimes, as I like to call it in bioethics, the F word, another term that has a lot of baggage associated with it, we have to think about what it means. What might it mean? We might have a sense of what it means in a physical health context, but the question I think that it comes up is that should we actually invoke this term in a psychiatric context? And so generally speaking, when we think about futility, it's something will not work or will certainly have no benefit. And much of the literature in this area comes from physical medicine or somatic medicine. And there's many actually different types of futility, but the three main types are physiological, quantitative, and qualitative. So for physiological futility, treatments might be considered futile if they are unable to achieve their various physiological goals. So for example, if someone comes to the emergency room and is having a heart attack and you give them orange juice, the orange juice will actually be physiologically futile. It just won't work in helping to treat the heart attack. Second type of futility is called quantitative futility. And this is originally defined as if in the last 100 cases from clinician experience or in the medical literature that the approach didn't work, then the treatment might be considered futile. So you're actually looking at the probability of success of a particular treatment. And so if the treatment is very, very low, one might say that it is quote unquote worthless or not worth trying or quantitatively futile. The third type of futility is called qualitative futility. And what this refers to is whether the intervention itself will have an increased chance of leading to a quality of life that is deemed desirable and reasonable. But the important part of qualitative futility here is that it's defined by the person. So defined by the patient, defined by the person experiencing the condition. Because often, within healthcare professionals and teams, we may make subjective judgments or evaluative judgments about another person's quality of life, but we don't know what it is like for them to be living with that condition, what in terms their values are, what terms of their priorities. And so I think qualitative futility really, again, is important from that first person perspective of how they see the intervention fitting in with their goals and quality of life. Futility is rarely mentioned in psychiatry. Sarah mentioned this earlier in terms of, it's been discussed primarily in relation to anorexia nervosa. But I think, amongst healthcare professionals, like in our everyday practice, does some of our everyday language also imply futility? So for example, when people use language like treatment resistant, and a very contested term, or treatment refractory, are we implying futility here? Or terms like non-responder. Some of these terms, again, contested, may be considered very stigmatizing, but is there sort of an implication or assumption here about futility within some of this language? So going back to our survey of Canadian psychiatrists, what we found, we gave different case vignettes, and one of the questions we asked is for this patient, further interventions to cure. So again, focus on the cure here. will most likely be futile. And as we can see, primarily agreement amongst anorexia nervosa, schizophrenia as well, but to a slightly lesser extent, and then even further less so again for major depressive disorder. So, amongst this small sample of Canadian psychiatrists, there was sort of general trend, if you will, that curative approaches most likely will not work for the cases that we provided. This is a really interesting study that came out of the US a couple of years ago. And what these folks did is that they surveyed 212 psychiatrists in the US, and they wanted to characterize their attitudes about the management of suicidal ideation in patients with what they called severely treatment refractory illness. Again, so very similar to treatment resistance. And so what they did is they provided psychiatrists with the participants with one of two cases that were describing a patient with suicidal ideation. So that was either due to a diagnosis of borderline personality disorder or a diagnosis of major depressive disorder. And both patients were receiving all guideline-based treatment and also plausible emerging treatments. But what I want to focus on here, which I actually find quite fascinating here, is table 3. So the percentage of respondents who said that they were likely to provide a treatment, remember, these are psychiatrists, that they did not think would be helpful. So in cases around, for example, of psychotherapy or additional medication changes and neurostimulation, you had, perhaps aside from the neurostimulation case, you had like 30 to 45, over 45% of psychiatrists saying that they would provide a treatment that they did not think would be helpful. So I have questions about this, about why would a clinician provide a treatment to a patient that they did not think would help? There's the duty of beneficence, the duty to do good or promote patient welfare. If they didn't think this particular treatment would be helpful, why is it being provided? May it actually be potentially harmful? So this was really interesting here in terms of what the practice often looks like in cases with people who are living with extremely treatment refractory illnesses and who have perhaps, exhausted or have used sort of the entire sort of armamentum of evidence-based care and may not necessarily be receiving benefit, but are continuing to receive those interventions. I think, it's also important to consider that, futility, again, the F word, is a very contested concept in physical medicine and, even more so with increasing discussion in a psychiatric context. So what might that look like? And so not everyone is necessarily warm to the idea that futility is a concept that should be applied in psychiatry. And I think we need to entertain these perspectives as well. In the case, for example, of Geppert's work in anorexia nervosa, perhaps there's certain aspects of anorexia nervosa or severe and enduring anorexia nervosa itself that might impact what we might consider treatments to be futile. And perhaps that has to do with capacity-related issues that might have to do with the nature of the condition itself in terms of insight into these conditions. So this is all to say that, this hasn't been sorted, but something that there's a current ongoing debate in the literature. And this is what we're trying to address. And so this is something that we're currently or going to be resubmitting, actually, which is a project that we, Sarah and I and some of our colleagues internationally undertook, which was trying to create through a Delphi process a framework for addressing possible futility in mental health care. And so I'm not going to go into the details of this here, but what we did is we had a Delphi process which aimed to reach consensus on some of these items. We also had a meeting in Switzerland in the fall of 2024, where we came together to talk about these specific categories and come up with this framework. So because this is something that I think intuitively, or at least there's some moral intuitions that clinicians have about futility in mental health care, and folks perhaps need a way to address it. So again, this hasn't been something that's been tested, but this is something that we derived through this Delphi process. Another critical point when we think about concepts like futility and severe mental illness is the role of structural vulnerability. And I think this is critical to understanding, who might we, and I'm using we here in the sense of healthcare professionals, think some treatments might be futile for. How might futility actually intersect with ideas of the social and structural determinants of health, such as poverty, right? Do treatments merely not work because someone does not have access to it? Do other psychosocial and structural factors, impacting intersecting factors or intersecting patterns of systematic disadvantage impact someone's ability to engage in treatment and therefore contribute to its possible, quote unquote, success? So, it's not merely that the treatments do not work per se for someone's symptoms, although in some cases that may be true. But I think we also need to consider these broader factors in shaping how we how we understand these concepts and the assumptions that we might make. So if we think about futility intersection of palliative psychiatry, again, I think there's a few points here that I want to emphasize. First, and again, this will not be news to this crowd, but care versus treatment is never futile. There's often, I think, sort of an implicit assumption, maybe amongst some, that palliative psychiatry approaches or palliative care in general, or when we talk about futility, it means abandonment. And I think, just again, to emphasize that the care itself is never futile. There's always something we can do, even if it may not be active treatment. I think, as I mentioned just previously, we need to understand a lot of these concepts within the social determinants of health. Futility doesn't justify abandonment of care. Again, going back to this abandonment concept and that care is never futile, but rather we might want to think about futility in psychiatry as a signpost. Maybe this is an opportunity for goals of care discussion. Maybe this is an opportunity to reorientate our practice approach and treatment philosophy such that the people who we're caring for are best served in their current state of illness. And then finally, I think, for patients who have exhausted all evidence-based treatments, futility can help acknowledge perhaps the limits of psychiatry and offer a potentially compassionate alternative. So I think within that, being upfront with the patients and families that we work with about what psychiatry can and cannot achieve may help demonstrate trustworthiness to our patients and families, particularly those who may have good reasons not to trust us, and may sort of, further, be concerned if some of these concepts may be brought up in discussion. Here's just some additional considerations, ethics considerations for us to consider. I mean, Ali's going to go through some analysis in the next presentation, but, some things that have come up are like, who should receive palliative psychiatry? What is the access criteria? There is diagnostic uncertainty. When should we switch to palliative goals of care? What about the role of autonomy and capacity for treatment decision-making? How might the influence of symptoms contribute here? How do we balance care with reducing harms, right? How do we minimize, that side of the coin that Sarah spoke with, where people are at risk of both therapeutic neglect and overly aggressive treatment? In some cases, may there be a reduced focus of active treatments, and how can we do that for the patient's benefit and not cause further harm? Additionally, healthcare professional burden, might some of these approaches cause some moral distress in healthcare professionals where they're, doing things or working with a patient in a way that they may feel is not the right thing to do. So how are those questions addressed as well? And I think to another point, which I don't have up here on the slide, is, understanding, some disability-oriented perspectives. Have people maybe internalized some stigmatizing or negative attitudes about their psychiatric disability and feel that perhaps they're not worthy of certain treatments, or have internalized ideas that, their life is not perhaps worth living. And this may again relate to some of the notions of suffering that we heard about earlier. So I think, ethically, clinicians do have an obligation to have these kinds of conversations with patients when these issues do arise, and to clearly help define goals of care in a process of sort of meaningful shared decision making. So I'll turn it over to Sarah to close us off.
Thank
Thank you,
so
Dania.
much. Oh, the other Sarah. Okay, sorry, go back. Sarah Levitt, sorry.
Story of my life. So thank you so much, Daniel. So in terms of future directions and where we're going to go from here. Oh, next slide, please. So just as a summary, as we've discussed today, palliative psychiatry is a growing and compassionate, person-focused model of care, slowly being introduced into mental health care. But it doesn't come without its ethical dilemmas, though there are many opportunities that it might present. And as we discuss, future research really must actively involve people with lived experience, help us further understand and parse and refine how we respond to the different kinds of ethical concerns. And we need to establish some best practices here. Next slide, please. So that's everything for us today. Like I said, our emails are here. We love to talk about this. So anyone who's interested, please do reach out. We are running a study where we are recruiting mental health care clinicians across Canada for qualitative interviews, as well as people with lived experience from across Canada for qualitative interviews. And we'd love to hear everyone's opinions on this work. So thank you, and we'll close out there.
Well, good afternoon, everyone. It's great to be here again, as Dan mentioned. To be presenting with him, and then to him as part of the masters is really feels great to be here with everybody. So I'll go ahead and share my screen here, and we can get into having a bit of a conversation about what palliative psychiatry looks in the context of a couple of case studies that we have ready. But before we dive too far into that, wanted to share this table, which may be familiar to some of you, and it's, I think, a great way to look at the different treatment options under the umbrella that are available to, maybe individuals with mental health conditions. And I think it's also important to highlight that there isn't intrinsically one care model that is perfect or better than others. I think it focuses a lot on the experience and the clinical aspects of the care that each patient needs for their care. So when we look at traditional psychiatry, compared it to palliative psychiatry, and even compared against something like MAID for individuals that have mental health as their sole underlying conditions, as someone touched upon, is still in progress and isn't likely to be approved up until 2027. We can see a difference in the intention method, motivations, and some of the outcomes for these different care models. So under a traditional psychiatry model, when we refer to traditional psychiatry, what we really are referring to is these non-palliative models of psychiatry. The focus is on recovery from that mental illness, whereas under a palliative approach, it's more so, as it's been discussed today in today's presentations so far, is a focus on the quality of life of an individual while they live with that mental illness. And if we look at MAID, it becomes to sort of find an end towards that suffering that somebody maybe experiences. The methods through which we approach care under these different models also varies slightly, with traditional psychiatry looking at various curative intents to treatment, trying to remedy the core identified mental health issue that somebody maybe has, whereas palliative psychiatry is focusing more on managing the harms that people may live with and the suffering that they report to have, and shifts it to that more patient-centered view, where in MAID we're looking at a more controlled lethal dose of medication to provide that level of support and outcome for patients. The motivations that we might see across the board vary slightly in the way that we understand them from, I think, an ethical perspective, and we'll touch on them in the later slides as well. But from a traditional psychiatry lens, I think beneficence as a model of ethical consideration really shines forward and stands stronger at the forefront, whereas a palliative psychiatry approach seems to favor a more balance of autonomy and non-maleficence, so that prevention of harm and patient-centered care, where in MAID, I think you can argue that the motivation is even stronger for more autonomous driving of one's care. And the outcomes that we see in these different models is, ideally from a traditional psychiatry model, an individual finds relief from their mental illness, whereas in a palliative psychiatry model, it's more so relief from the symptoms or suffering that the person might be living with of that mental illness. And in MAID, it's relief from that suffering by death. So the key differences, I think, across these different models tends to be more so in the motivation with which we approach the care that we try to provide, I think, in a clinical space, and the intention with which we approach those patients. So to start off with one of the cases that we were going to sort of dissect, we have this case of Miss R rather. Miss R is a 42-year-old with major depressive disorder, the decades-long history of severe depression. They've gone through multiple medication trials and have gone through extensive psychotherapy options. They're coming off of a 3-month admission in the hospital for ketamine therapy. And throughout their care journey, there hasn't been a sustained improvement that's been reported by the clinical team or by the patient themselves. They maintain to be at a chronically high baseline level of risk for suicidality and express a long-standing expression of hopelessness with their condition and when it comes to their outlook on life. They state things like, "I'm done. I just want to leave the hospital and die." To add some more context to this case, the family dynamics of this patient are that they have a partner and a young child living in the community. They had an adult daughter who fortunately died due to a drug overdose, and a parent who had received MAID for degenerative illness after the death of their adult daughter. So these dynamics are reported by them to complicate the way that they feel about their own life and their sort of situation. In their current state, they describe their depression as unrelenting and that they cannot recall a time in their adulthood when they felt well. And they report that they will go into the community when that option is available to them and plan to die by carbon monoxide poisoning on a date of upcoming significance for them. So I think that this case presents a difficult vignette of how do we approach and support this person in providing them care. And when we look at the models that we're talking about today, that traditional psychiatry approach and that palliative approach, I think they motivate us to approach this case from a couple of different lenses, and that's what we'll walk through in the next couple of slides here. So when we look at more of a traditional psychiatry approach, I think some of the core assumptions that are first made or that come up is that depression is treatable, that suicide is preventable, and potentially that risk mitigation is of primary significance when trying to find some form of a resolution or solution to the issues that might be presenting for the individual. And that leads to a clinical focus that is potentially an immediate risk management approach towards the suicidality that the patient is reporting, considering escalating the treatment options that we provide the individuals, as well as safety planning and possibly continuing involuntary admission for the person if that seems like it is the appropriate option, as well as restrictions to access means that the person might have within the community otherwise to carry out wishes that they may have communicated to us. And I think in this model, hopelessness that the patient feels is sometimes seen as a symptom of the mental health issue that they're facing, and we're able to then solve and cure that mental health issue that's underlying. In this case, we're able to cure and provide support to that hopelessness or feelings of suffering that this individual might be bringing to the table or coming forward with. And when we look at kind of the ethical orientation of how we support this sort of view of providing care, the duty of beneficence, as we talked about earlier, stands at the forefront, where we're looking at the idea of providing what is best for the person, or this idea of we should be sort of cure and goal oriented in that provision of care, where remission is the goal that we're working towards, because out of a duty of beneficence or doing good, that's the best good that we can do for this person, is provide them that cure to the situation. When you look at the situation from, I think, a lens of non-maleficence or a lens of preventing harm, the person's expressed this idea of suicidality putting in place methods that allow us to help them reduce the likelihood of being able to commit those acts or to being able to move forward with any plans is the model that makes sense because we're trying to prevent the harms that the person might feel. And what this, I think, can also lead us to look at is justifiably, therefore, limiting the autonomy of the person. Because if we're coming at this case in a situation of the best interests of the individual, preventing harm, we may be able to be justified in saying that we're going to prevent maybe the autonomous wish that this person has to go back in the community or not participate in care or to not be patriated within a hospital, and maybe put them in an involuntary hold or involuntary admission for a longer period of time, because that prevention of harm is of a more central importance to us, or a more key consideration under this model of care. When we look at palliative psychiatry potentially as an approach, some of those core assumptions are challenged, that depression is treatable, or that the suicide that this person may be expressing, or that expressions of suicidality are preventable, and shifts again that focus, as we've seen in the presentations that have been shared so far, is towards more so of a relief of suffering, or understanding how can we implement a better quality of life, or help this person work towards finding a better quality of life for themselves, and even consider avoiding what we might think of as burdensome interventions of care or of treatment, and acknowledging that there are limits to disease modifying care, and that we do have limits to what we can provide somebody from a clinical approach in reaching what we might consider to be a cure for the patient. And it's important to understand, I think, as well with these palliative approaches, that it's not that we're permitting or promoting suicidality or allowing individuals to go back into unsafe or potentially dangerous situations, but instead we're trying to understand what relief from suffering might be for that individual patient, when cure isn't likely based on the treatment options we have, and based on the idea that we've tried a number of treatments, nothing has worked, and that model of care where we're continuing to promote curative intent is not likely to lead to a potential or remarkable benefit. So that's where I think the reorientation in a clinical space for palliative psychiatry comes into play, where we're asking questions about the nature of suffering for the person. So as Salmo kind of, I think, touched on really well in the beginning of the presentation, of where is this suffering coming from this person? They've gotten to a point where they're expressing that they don't want to continue with care. They want to go home. Maybe they want to die. They're expressing very frustrated ideations. And where does that come from is something that we can try to investigate in those clinical conversations, or within that space, to understand where the suffering or the sorts of suffering that this person might be experiencing, and that allows us to promote or present treatment options that allow for that person to be supported and not feeling that weight that they might have otherwise of the mental illness and the symptoms and the suffering that comes from there. Asking questions around what does death planning represent for this person can be ways to help us reorient our clinical sort of lens and perspective on these cases. Asking questions like, does furthering aggressive treatment or other treatment options meaningfully improve the life of the patient and have benefits for them, or does allowing this person to transition towards something that helps them feel more in control of their condition serve as something that is potentially more beneficial? And that's where we look at hopelessness not only as a symptom of mental illness, but a form of suffering that the person is dealing with, and providing support for that then allows us to come up with potential strategies that allow us to provide a more patient-centered approach and an outcome that is, I think, more reflective of what the individual may want for themselves. So when we consider, again, the ethics and the principles of this approach, I think we reframe some of our duties that we talked about in one of the previous slides there. So that duty of beneficence, the idea of doing good, is still, I think, very much present. The idea that we want to provide welfare to this person, we want to do what's the best for this person, but it doesn't necessarily mean that cure is the only way to get there. I think this is Dan touched on well in his slides there is care can still be positive, even if it's not curatively intended. When we look at the duty of non-maleficence, we broaden that beyond just prevention of harm to the individual, but looking at the harms that continued treatment, hospitalization, and escalating treatment options might have on them. And what this does is it doesn't promote us to limit that person's autonomy, but more so to respect it and have more honest conversations about what the limits of treatment might be based on their clinical presentation, and allows for shared decision making even when there's a level of chronic risk that might be present within this case. So if we look at, again, the intentions of these different methods, and the way that we maybe come at this situation from a clinical perspective, and we look at the potential clinical approach that maybe leads to, if we first start with the traditional psychiatry lens on the left side here, if the intention is prevention or cure, and the method through which we achieve that is escalation of treatment and management of risk for the individual as a primary concern, the potential outcome that you may suggest for approaching or presenting as a method of care for this patient might be to promote new treatment options for the patient and continuing their hospitalization. Whereas transitioning to a more palliative approach to their care, or palliative psychiatry lens, where the intention is to reduce the suffering that the individual is experiencing while maintaining that there may be a risk of suicide that this person has shared with us, and trying to prevent and manage that risk. We also see that the method through which we would approach that care focuses on increasing that quality of life. And the clinical approach that then leads us to is considering potentially a community-based care plan with appropriate risk mitigation strategies in place that help to reduce the risk that this person may face of suicide. So within these two outcomes, I think, or these two methods, you see a variety of outcomes. One that promotes potentially a more clinical long stay, promoting continued medication or promoting other sort of treatment options, whereas a palliative approach maybe then allows us to more so consider options that allow this person to return back to the community with a safety plan in place and doesn't further burden them with hospitalization or involuntary stay within the organization. Another case I think to consider here is that of PL. PL is a 23-year-old with severe and enduring anorexia, long-standing eating disorder, and severe malnutrition. They have ongoing medical and psychiatric complications as a result of their anorexia, resulting in frailty, weakness, and a number of acute and chronic health issues. In the past 12 months, they've faced 8 hospital admissions, and each admission has required an intensive level of medical stabilization, nutritional rehabilitation, and often involuntary treatment and forced feeding. And the patient in this situation is finding themselves emotionally depleted and is sharing that they can't keep doing this. And the care team is now posed with this difficult situation of how do you continue to provide care to this person, or what can we do to support PL in this situation? And I'd love to open it up here to the other panelists to provide some input on, what, if any, indicators within this case would tell us that a shift in goals of care towards palliative psychiatry might be more appropriate for this case, or if palliative psychiatry doesn't feel like an appropriate option within this situation here.
Sumit?
Yes, I'm happy to take on first. Thanks, Ali. This case series has been really reflective into all the complexities, and understandably, these do not have simple, straightforward answers. My first thought, and that's probably a limited thought, is to look at an approach which is very much a narrative medicine approach, which draws out what suffering is and what suffering means to this particular person, It kind of speaks to shift in focus uh, from what we are treating, which is of course anorexia, to who we are treating, which is the person behind the anorexia, right? And I think we need to kind of shift that focus. A lot of, at least my training has been into the recovery model of care, which is rooted in, yes, go for it, one more DBT session, one more hospitalization session. And I think the shift in focus for mental health professionals is so difficult from a recovery model to something which is, it's not impossible, but meaning it's an extension in many ways, but that's something that comes first to mind. But yes, of course, looking to hear from Sarah and Anne.
Yeah, thank you. And thanks for this really, thought-provoking presentation that really grounds us like back into the clinic, which as a clinician is obviously my whole interest in all this. Um, yeah, I largely agree with what Samil kind of outlined in terms of thinking through shifts in goal of care really from a person-centered perspective rather than a diagnosis-centered perspective. And I think, like in terms of grounded clinical skills that I would use here, I to answer this question, I would really try and understand like this person's subjective like experience when they say that they can't keep doing this. What's the this? What does this mean? What have been their experiences of these, 8 hospitalizations, all the different kinds of treatments, the way that their illness has impacted them in the different domains of their lives. And I think that that would provide a lot of guidance um, on how to understand goals of care. Um, I also just want to say, like, I, I've been thinking about it a lot in terms of the recovery model, and I think it's really important to always be keeping in mind the distinction between like medical recovery and personal recovery. And yes, like I think there are so many tensions between maybe like palliating mental illness and medical recovery. I just don't see the same kind of tensions personally between palliating mental illness and personal recovery because isn't personal recovery all about quality of life? So it still feels very aligned for me. And I think the other thing I think about when I look at this case, like you can't help but notice that this is a very, very young person. So the other thing I'm thinking about is as these healthcare models are developed is how do you make sure that once a clinician decides like and ideally in a shared decision making, how do you make sure that that's sort of not like fossilized, like that there is a lot of reevaluation, that people may shift in different kinds of models of care. I think that this is a really dynamic thing because there is uncertainty. And so there needs to be sort of reevaluation along the way because goals can always change.
Yeah, no, I think that makes sense. And I remember from a conversation I was having with someone the other day, you mentioned that, I think you put it really beautifully, that palliative psychiatry is just an extension of psychiatry, like palliative care is an extension of traditional healthcare, right? It's not that you're reinventing the wheel, inventing new, but it's shifting that focus on to the patient and the realities of what they are experiencing and providing them support, I think, to get through to the goals of care that they've shared with you and a constructive path forward on finding a form of respite and relief when cure no longer seems to be an attainable or realistic, or even in maybe some cases, a willing goal that a patient wants to engage with. Yeah. Happy to pass it back to Sarah Anderson if there's maybe questions in the chat, or be happy to discuss.
There is, Ellie.
Time.
Janice asked, does psychiatry at this time look at a past history of trauma and provide treatment for past trauma, which could include intergenerational trauma?
Yeah, I can take a stab at that one first, but curious to hear from the other panelists too. So I would definitely, I think that most mental health care providers now are trained within, at least in Canada, are trained very much within like a trauma-informed care perspective. Um, and it feels often like sort of second nature to incorporate those perspectives. Of course, it's not always done perfectly, and I'm not always sure about like the person who's receiving the care's experience of it. I think there is an accounting for intergenerational trauma, though perhaps a little bit less of a focus on it. And I'm not sure. I think we have lots of like epidemiological understandings of how to incorporate intergenerational trauma into our formulations of why someone might be experiencing symptoms a certain way, and also some understanding of how intergenerational trauma impacts social circumstances, family dynamics, attachment theory, etc. Um, but where I see still a shortcoming is I'm not sure we have good systematic models to kind of think about how to really process with patients how their experiences of care itself is could be experienced as a trauma, um, and really like work on a repair. I have lots of hypotheses about how this actually like impedes future experiences of healthcare, like, in terms of if someone had a really traumatizing experience on an inpatient unit, of course, that would make them less likely to go seek out care in the future, leading to perhaps a worse episode of illness and like theoretically more treatment resistance. And I think there's like an awareness of it, but I don't think we're really good at systematically like evaluating it and like actively addressing it in a proactive way with our patients at this time, which certainly could be relevant to these discussions of palliating mental illness.
Thank you, Sarah. There was one other comment, just wondering about quality of life for this individual. States I'm not familiar with this, but would she be having some organ failure at this point, and what would her quality of life be?
I guess I can take that. And Ali, probably you're the best person to jump in from a case-based perspective. But yes, that's the layer of complexities that add on in the clinical world with how close is one to death and dying, and that starts kind of weighing in into how we start defining care interventions. Um, and it's so heavily weighed into how the person uh, sees how their care needs to be defined, at an intersection where, say, organs have failed, and there could be uh, other values that might be driving their goals of care idea. And Sarah mentioned about how the personal goals of care and the palliative model of care are in alignment in many ways. And so that makes it, meaning the palliative care model makes it certainly less emotionally distressing, morally distressing from the healthcare team to intervene from that level. And to the point on quality of life, I think Daniel brought that out beautifully in the presentation of about uh, how it's a value judgment about quality of life in a particular aspect, that uh, how who decides, how do we decide what is quality of life at a point in time, and the corresponding treatment interventions, whether they are considered physiologically or qualitatively futile. Um, so I think those conversations are something unique to this model of care.
And I think when reflecting on, specifically, I guess the question was referring to the anorexia case there at the end, but situations where SPMI is present, and I think Sarah talked on it a little bit, it's not that there's any one particular mental illness that it covers. It can present in lots of different ways. The difficulty for a lot of clinical teams, I think, becomes the understanding of a person's capacity to be an active member within or of conversation as part of driving their goals of care. So in the space of anorexia, I think oftentimes patients that present with it tend to be very rational and communicate quite well with teams up until a point where there seems to be an understanding of, well, this person understands and appreciates a lot of what they need to make decisions about their care, but when it comes to something like feeding, they're unable to engage as meaningfully in those conversations. And it makes it difficult for the care teams, I think, to be receptive to these more palliative approaches. But when we frame, I think, palliative psychiatry as a model of care or a form of care, I think it allows us to decenter what might be our assumptions as what a patient should accept or what a patient can understand towards that collaborative, patient-centered model of what that individual wants, and allows for us to then feel like it's not that we're not providing the interventions or that we're not helping them, and allows us to move towards a model of care or sort of care options that takes into account providing a outcome that is more so needs-based for that patient.
There are some other questions in the chat. One being, is palliative psychiatry currently in practice or primarily theoretical at this point?
So I mean, I'll do half of the response, and Sarah, you can do the other half. So my understanding is that as sort of the term palliative psychiatry is very new, and maybe how we're describing it, may be sort of a new sort of conceptualization of it. But we've learned over the last few years, especially working with people who provide mental health care and support, including housing and other sort of social supports in the community, how palliative psychiatry is talked about or spoken about under that label. People have actually been doing that for a very long time, or certain aspects of it, but maybe not calling it that. And so people may have been, were very focused on some of the relief of suffering as a focus, or the psychosocial aspects of it, or have been like, yeah, we're not talking about curative approaches. Or maybe there's, other things in the area of substance use, like heroin-assisted treatment, for example, might be considered a palliative approach, right? Or something within palliative psychiatry. So I think, people may be practicing what we're sort of labeling as palliative psychiatry and not calling it that, or even thinking that they're doing anything out of the ordinary. So I think there's a lot of wisdom there within especially in community-based contexts, to learn about those approaches and work with folks who are doing that, including like peer support workers and other folks with lived experience, and other sort of communities, and how to work with them to understand what's going on, and provide additional benefit for patients and clients and other service users.
Another question. My background is palliation, not mental health. I see where children die in hospitals, at home, in hospice, and for adults, the same in hospital, hospice, or at home. I've never seen a palliative schizophrenia or anorexia patient or case. Where is the location of death?
Yeah, it's a very good question. So, I mean, I think they are also dying in hospitals, hospices, and homes, but maybe not being labeled as dying of their illness as such. So, we do know from the anorexia nervosa population in literature, there are actually like a lot of reported case examples of them going to hospice, and there are some emerging hospice programs being established specifically for their needs. That's being done in the States. There's some in Europe. And I know there are some hospices in Canada that are not unfamiliar with accepting patients with an anorexia diagnosis as their primary reason for admission into hospice care. Otherwise, yeah, I mean, I think that sort of lots of people end up being admitted to a hospital because of sort of catastrophic sort of medical consequences of their symptoms of mental illness. They die in hospital. Lots of people, might have accidental or non-accidental deaths in homes. So, it's really no different. I would say the one difference is that we know that people, particularly with primary psychotic disorders, have consistently died 20 years younger than age-matched controls. Even as our population has aged, that statistic is held true. And we also know from sort of the palliative care literature, actually done by a Canadian, Chochinov out in Manitoba, that population dies more often in long-term care facilities and in hospitals despite a wish to be dying at home, and they receive less palliative care in general, less pain medication, there's less sort of symptom control of their sort of end of life type symptoms. So I know that wasn't really a focus of this presentation, but I think as Sarah A said at the very beginning, it just highlights a lot of the different equity issues at play here.
I'll just add just a shout out to two of our close colleagues and collaborators. An Ottawa-based colleague, Dr. Serena Eisenberg, who folks may know at Briere. She's doing some really great work on looking at location of death among people with severe mental illness and also with opioid use disorder. So keep an eye out for some of her work. And also Dr. Kelly Stagihar, who's a colleague of ours, who's a nurse, palliative care researcher out at the University of Victoria, who does a lot clinically and research in palliative care with structurally vulnerable populations, particularly people experiencing homelessness. So especially looking at those, so very much looking at where people die or wish to die.
One last question. Wondering about what supports or advice you may have for people with severe mental illness who have behaviors that make it difficult for them to live within traditional care centers like hospice or LTC when they also have a serious physical illness.
I can start there. Yeah, very good question. Right now, I would say that we don't have incredible answers here in Canada. There is some good news though, which is that in some other places, they are starting to look at models that I'm really hoping Canada learns from and adopts. So I would really encourage whoever asked this question and whoever else is interested to look up the literature on oyster care, oyster like the sea creature. It's a model of care that is being run out of Belgium in the Flemish region of Belgium. And it's this really, in my opinion, beautiful model of care where they've actually built a facility. And folks who experience symptoms of severe and persistent mental illness can enter that facility for all manner of different reasons, either like their symptoms of mental illness and physical health conditions, or just sort of their intractable symptoms of mental illness that are creating a lot of difficulty for them to live. Like in general in the community. And, their focus is really on making sure that there's like no restraint, that they take lots of harm reduction approaches. They really just try their whole analogy of the oyster is that the person's symptoms are part of their coping mechanisms and help make them special and help them like live with realities. And so rather than trying to like destroy that pearl in the middle of the shell, you have to build the protective shell around that. And that's what they're trying to do with this model of care, facility, etc. So, I don't have a really good answer right now in Canada. I think it's something our system really struggles with, but I think that there are solutions that have proven feasibility and are working in other places in the world. And we have a lot to kind of learn and figure out how to implement in our own culture and context.
Okay, thank you so much, Sarah. I believe I captured the majority, or if not all, the questions. Val has put some information. There was a question about dementia care and the intersection of dementia care and mental health. There's going to be a session next week. So Val's put in the link there if everybody wants to check that out. I'd like to thank all the guest speakers for sharing their expertise, insight, and reflections on such a complex, important topic. There was a comment in the chat thanking the group, just mentioning that there's so much more discussion and research that's needed on this topic.
Great. Thanks, everybody.
Thank you.
Thanks.
Thank you.
Thank you.
Thanks so much.